which followed 1,000 different couples, of whom half were HIV negative. In this trial, PrEP was used as a bridge to antiretroviral treatment. They saw only one HIV infection from November 2012 to August 2014, when 21 were anticipated based on modeling. In addition, the ADAPT trial looked at various dosing schemes, and they found that daily dosing allowed for the highest adherence. There were no difference in HIV infections between arms, but this trial importantly suggested that in an open label setting, young women are able to maintain adherence, with 80% having substantial drug levels at 1 month and 60% having substantial drug levels at 6 months. The WHO guidelines address in detail concerns for drug-resistant development in the setting of PrEP, particularly given the evidence that I just showed you about non-adherence. The meta-analysis found that there were 8 cases of drug resistance that developed among individuals who were infected with HIV before starting PrEP. This group, not surprisingly, had high proportion of drug resistance, as you can see, at approximately 37%. However, among individuals who were infected with HIV while taking the study drug, the proportion of drug-resistant infection was actually quite low, approximately 3%. Moreover, when we look at the overall risk of drug resistance among the over 9,000 individuals in PrEP trials, the risk of developing drug resistance while on PrEP is approximately 0.1%. Put in the context of the anticipated risk of developing drug resistance for each year on antiretroviral treatment, which has been approximated around 5 to 20% in some studies, PrEP seems like a safe and reasonable option. Specifically in women, the FemPrEP data was reanalyzed to look at the risk of developing resistance among women who seroconverted while taking PrEP. FemPrEP was a randomized control trial of oral PrEP of 2,100 women in Southern Africa that did not show a significant reduction in HIV infections. This new study looked at analysis of women infected with HIV while on PrEP and showed that seroconversions that occurred in the setting of low drug levels did not breed resistance, while seroconversions that occurred in the setting of detectable drug levels did lead to resistance. However, many of these cases were suggestive of infection that had occurred before the initiation of PrEP. One of the confounding factors that we still don't know exactly when PrEP reaches protective levels in the specifically vaginal compartment. We know that it takes longer than to reach protective levels in the rectum, but we don't know exactly how much longer. In addition, this study demonstrated that HIV infections can occur in the setting of drug levels that correlate with taking 4 to 5 pills a week, levels that had not previously been seen in the setting of seroconversions in men. So the takeaway from this study continues to be that PrEP works when taken, but adherence data really needs to be coupled with improving our understanding of the female genital tract, and specifically why women might be more susceptible to infection given the same drug level. Finally, the WHO systematic review demonstrated that PrEP is safe by looking at 10 randomized control trials and found no difference in adverse events between PrEP and placebo arms. There was a subclinical decline noted in some studies with respect to renal function and bone mineral density, but these were not clinically adverse events, and no progressive decline was seen over time. Based on the evidence that we reviewed, the WHO recommended offering PrEP to anyone at substantial risk of HIV. We're now going to tease apart how the guidelines came to that recommendation and then talk about specific recommendations in pregnancy. So let's go through exactly what the guidelines mean by substantial risk. This recommendation was based on a modeling study, which was trying to define an incidence threshold at which the cost of PrEP was less than the cost of antiretroviral treatment for an averted infection. Consequently, in this setting, PrEP would be cost-saving. In this model, the group recognized that any incidence threshold would be dependent on the effectiveness of PrEP, which you can see on the x-axis here, and the ratio of the cost of PrEP to antiretroviral treatment, which is shown by the different colored lines. The WHO acknowledged that while drug costs vary, a reasonable assumption is that PrEP is approximately 40% the cost of antiretroviral treatment. In addition, efficacy of PrEP in demonstration projects has been around 80 to 90%. Consequently, an incidence threshold at which PrEP is cost savings is approximately 3 per 100 person years, which you can find by following the black line from 80% over to your y-axis, which is between 2 and 4%. Just of note, how we operationalize these guidelines is going to be challenging, and we're hoping for future guidance in the upcoming implementation notes that should be come out in 2016. When we look at the incidence rates seen in placebo arms of the PrEP trials, we see that the majority of trials attracted populations at substantial risk as defined by WHO guidelines, again supporting the fact that high-risk populations want to and are able to use PrEP. The WHO guidelines specifically address eligibility in and around pregnancy, stating that the risks and benefits and alternatives of continuing PrEP during pregnancy and breastfeeding should be discussed with each individual, and further research is obviously needed. We're now going to go through the data that we have to date. The WHO cites an approximately twofold increased risk of HIV acquisition during pregnancy, and various observational studies have found an association between acute HIV during pregnancy and breastfeeding and an increased risk of perinatal transmission to varying degrees, some on the order of 4 to 8-fold increased. While there's emerging biologic data supporting these increased risks, these observational trials are nevertheless confounded by differences in condom use and sexual practices during pregnancy, specifically with respect to the risk of HIV susceptibility during pregnancy. And the latter studies looking at the increased risk of perinatal transmission in the setting of acute HIV are confusing to interpret in the setting of varying antiretroviral treatment dosing and if treatment was offered at all. A recent systematic review attempted to summarize the risk of HIV acquisition during pregnancy and the postpartum period, and found an increased risk of HIV during pregnancy, but one that was not statistically significant. The hazard ratio there is 1.3, but as you can see, crosses 1. The postpartum data was really too limited to draw any conclusions. However, what we can conclude from this information is that at a minimum, women's risk of HIV infection is unlikely to go down during pregnancy and may likely go up. That brings us to the consequences of acute HIV infection during pregnancy, which we'll discuss in the next slide. While the amount of the increased risk of vertical transmission that occurs with acute HIV during pregnancy likely varies in the setting of various types of antiretroviral treatment, there's a clear trend towards increased risk of vertical transmission when infection occurs during pregnancy. Here we get to the crux of why I'm giving a talk about PrEP to a group that's focused on elimination of perinatal HIV. As maternal antiretroviral treatment becomes more widespread, we may anticipate seeing larger proportions of perinatal infections due to acute HIV during pregnancy, which you can tell from the graph on the far right. In order to truly eliminate vertical transmission of HIV, we must include focus on preventing maternal infections, both between pregnancies and in particular during pregnancies, when women may be particularly vulnerable to infection and certainly have an increased risk of vertical transmission. Hopefully I've laid out for you the rationale for considering PrEP during pregnancy and lactation. And so the follow-up question is really whether PrEP is safe in these periods. The only data that we have currently on PrEP use during pregnancy is from the Partners PrEP data, in which PrEP was discontinued and pregnancy was detected. So on average, these pregnancies were exposed to really only 5 weeks of PrEP. There was no difference detected in pregnancy incidence, birth outcomes, or infant growth, but there was a possible signal that PrEP was associated with pregnancy loss. This was not statistically significant, and we know that the etiologies of miscarriage are wide-ranging. and therefore we're still really in the realm of not having adequate data to state whether there's an effect of PrEP or not. All of the data that we have on tenofovir with or without emtricitabine during pregnancy is from women living with HIV and from women living with hepatitis B in pregnancy. We know that tenofovir readily crosses the placenta, and from the antiretroviral pregnancy registry, we have enough data to know that there is no increased risk of birth defects. The majority of studies suggest tenofovir does not impact intrauterine growth. The relationship between tenofovir and preterm birth is complex and controversial and challenging to tease out from the impact of other antiretroviral drugs. So I'm going to actually sidestep that topic given our limited time and summarize that tenofovir remains a first-line treatment for women living with HIV during pregnancy. There's also a suggestion of tenofovir's impact on neonatal growth after delivery. While 2 trials in the US and Africa showed no difference in growth at 6 months and 2 years of life, the FACTS trial in the US demonstrated a decreased length in head circumference at a year. However, it's important to note that the long-term clinical implications of these findings are entirely unclear. More recently, significant attention has been paid to the impact of tenofovir on infant bone development. Again, all of the data to date are from HIV-exposed infants. The SMART trial demonstrated that at birth, infants exposed in utero to tenofovir had 12% less bone mineral content, which was statistically significant. However, we have no long-term data available, and in particular, these changes may go away after the in utero exposure ends. It's also unclear if combination antiretroviral treatment is different from tenofovir alone. Further complicating the story, the FACTS trial recently reported that they didn't find any dose response between tenofovir levels detected in meconium and bone mineral content. We have even less data about tenofovir during breastfeeding, besides the information that very small quantities of tenofovir and emtricitabine are secreted in breast milk. We may gain more information as more women living with hepatitis B take tenofovir while breastfeeding, but this data remains extremely limited. So just to summarize, data specifically on PrEP during pregnancy and lactation is limited to the very early first trimester. And while we can extrapolate information from women using tenofovir as treatment for HIV and hepatitis, we really need specific data on women using these drugs as pre-exposure prophylaxis who are HIV negative to completely understand the benefits and risks. We know that contraception is an important means of allowing birth spacing, reducing preterm birth and maternal mortality. And if there's an increased risk of HIV susceptibility during pregnancy, contraception may be a means of reducing maternal and perinatal HIV infections. Recently, certain contraceptives, specifically Depo, have been associated with increased risk of HIV transmission. However, the Partners PrEP trials importantly demonstrated that Depo did not reduce the efficacy of PrEP. In addition, some studies have suggested that hormonal contraception efficacy at preventing pregnancy may be decreased in the setting of PrEP. However, a recent large trial showed no difference in contraceptive efficacy among women using oral contraception, Depo, or implants. We urgently need more data on these drug-drug interactions, but most importantly, how we can share lessons learned from the fields of postpartum care, family planning care, HIV prevention care, so that we can reach women in particular during periods when they frequently fall out of care and may be particularly vulnerable to HIV infection. I know I've run over, but I really briefly want to mention one group that's not explicitly addressed in the WHO guidelines, because this group unquestionably needs to have focused research and implementation attention. UNICEF recently reported this summer that there are approximately 140,000 15 to 19-year-old young women living in areas where their HIV risk may be substantial according to WHO standards. PrEP to date has really not realized its full potential in specifically young women, and we need to better understand drug safety in young people, and specifically the long-term impacts of potentially multiple cycles of PrEP, starting and stopping over a woman's reproductive lifespan. We also need to better understand implementation in adolescents and specific subpopulations of adolescents, in particular pregnant teens, to address some of the enormous barriers to PrEP use in this population. So to conclude, what we can anticipate in the next year are, most importantly, the WHO will publish implementation guidelines in 2016. Nevertheless, we know that the data is inadequate for detailed implementation protocols based on what we've discussed today, particularly for women in and around pregnancy, and especially in those women who may be at increased risk of HIV susceptibility and therefore perinatal transmission. In order to fill these knowledge gaps, we need to improve understanding of the female reproductive tract and specifically how PrEP acts in women and in women during pregnancy. We need better pharmacologic data in women and again during pregnancy. We need to investigate alternative drug dosings, modes of delivery, including gels, rings, injectables, and multi-purpose technologies in order to better reach a wider range of women. Based on today's review of the data, I hope I've convinced you to agree with the WHO's recommendation that while there are still many unanswered questions, we have enough data to begin implementation efforts now. And so with that, I wanted to thank Shafiq for inviting me to talk today, and in particular, Dr. Bob Grant for sharing his slides with me, and Jessica Rodriguez for coordinating this webinar.
Thank you so much, Dominica, especially as you're joining us from the west coast of the U.S. and you had to wake up quite early to be with us today. Thank you for really outlining some of the potential impact of pre-exposure prophylaxis in regards to some issues and challenges we're seeing, especially seroconversion during and right after pregnancy in some countries, as well as its implications for young adolescent women. So we'll open it up for a few questions, and thank you, Shafiq, for managing the Q&A online via the chat. Many of the questions that have been posed have been addressed, so I encourage all of you to scroll through to see if maybe a question you had has already been addressed. And we also will distribute a webinar summary that synthesizes and summarizes all of the questions and responses as well, so if you missed any.
Jessica, can I chime in one second very quickly? A couple of questions have come up from folks around PrEP specifically. If people are happy to stay on for a few more minutes, I'd love to take the opportunity to have Nika on the line with us to be able to get her input to those questions. So Nika, I don't know if you've been reading the chat, but one of the questions has related to testing prior to initiation of PrEP. Since you're using PrEP in people that are already at substantial risk, how aggressive do you have to be about making sure that they're not infected before you start PrEP? Do you need to, for example, use a virologic test as opposed to serologic tests before you initiate PrEP, especially where you're concerned about the level of risk? And the other question that has been asked is, what kind of service delivery points do we think PrEP will be offered at? And this question of substantial risk, is this something that is a program's duty to try to answer, or is it something that an individual tries to assess? How in practice does a clinician deal with understanding substantial risk?
Those are such outstanding questions, and all of them get to the heart of what it means to prescribe PrEP both on an individual level and on a population-based level. I'm going to start with talking about the testing question because that is the most concrete and easiest. Absolutely, in an ideal world, our goal with testing is to prove that at the moment that we prescribe PrEP, that the individual sitting in front of us is HIV negative. However, in reality, we know that people who we're prescribing PrEP to are at high risk of HIV infection and are having ongoing exposures. So it's actually very challenging in reality, and this we have absolutely seen in the demonstration projects to date, to find points in time when we know for sure, based on the window periods of tests, that people are HIV negative. What the WHO has chosen to do, and this is begun to be explored in the implementation notes. My expectation is that in the more thorough implementation guidelines that come out next year, this will be addressed in significantly more detail, is that countries should not delay implementation of PrEP based on the type of HIV testing that they have, meaning that people should use the highest generation test with the smallest generation window that they have available, but shouldn't delay implementation or start using tests that are not validated in that location. In an ideal world, a fourth generation test is probably the most kind of practical test that we might be using, and that's what's being used in many PrEP testing sites in the US today, with a backup of using virologic testing for people who show signs or symptoms of acute HIV. An alternative way of approaching this dilemma is to incorporate PEP, or post-exposure prophylaxis, with a more expanded drug treatment. And the WHO guidelines don't go into extensive detail about how PEP will be incorporated into the implementation guidelines, but it really is a central part of any PrEP delivery program because people who present for PrEP have ongoing risk. So just to summarize, the WHO guidelines state that places should continue to use the HIV test that they have validated in their context. People should be screened for HIV at the start of PrEP initiation, and in particular, if people are likely to be in the window period, while current guidelines usually recommend waiting to retest in about 3 months, we might consider increasing testing more frequently. However, we still don't have data on those specific recommendations, and we're hoping as more demonstration projects look at PrEP implementation in the real world with people who are having ongoing exposures, we'll get better information about how frequently to test for HIV and what's the most cost-effective test to use. With respect to the question about how to address the question of substantial risk, this is really the murkiest part of the guidelines, and how can a specific clinician operationalize them is a really important question. I think it's important to take a step back and recognize why the CDC went in this direction with the guidelines. And really what they're trying to say is that while previous guidelines had basically made blanket recommendations about entire populations, for example, about men who have sex with men, they now recognize that, for example, a female sex worker in one region of the world might be at substantially high risk of HIV, while a female sex worker in another region of the world might actually have quite low risk of HIV acquisition. And therefore, providers need to balance what we know about population statistics with their local context. And so how that works for an individual clinician, it really means knowing your epidemic in your community. And the WHO recognizes that this is going to be really challenging to operationalize, but they're trying to give clinicians and individuals the freedom to recognize that in every part of the world, there are places where people have high risk of HIV, and there are people who are actually at surprisingly low risk of HIV. So we can't make sweeping recommendations based on a population or a location, and really have to look at the specific local context of an individual. I think the last question was about service delivery and who might be providing PrEP. That is an also incredibly important question. And I think specific to this webinar, many people have called for utilization of family planning services to provide PrEP. First of all, because these are places where women access care. And second of all, they're not associated with the stigma of attending an HIV clinic. In the United States, there have only just recently started to provide PrEP at family planning clinics. And really important implementation questions remain around family planning providers' comfortability, knowledge of PrEP and antiretroviral therapy, and really expanding the services they provide and whether there's enough room in those clinics to provide that integrated care. I think on a public health level, we know that integration of care is most likely the most efficient way to go, but actually training up providers to be able to provide that service and then having the lab testing and follow-up services that are required for PrEP, which are more intense than other birth control methods, will be a challenge. I hope I addressed all of those questions.
Yes, thank you very much, Dominika, for addressing the questions. I think you did a very thorough job. If anyone has any other questions, feel free to type them in and send them in, and we'll try to address them via the chat or very quickly. There's one that says, how do you suggest one goes about convincing an individual to use PrEP in the context of combination prevention? For example, using PrEP as well as condoms when we have already told them that PrEP will prevent them from becoming infected.
So another great question. The key word here is I would really encourage us to start thinking about our language and make sure that we're never strongly recommending or encouraging someone to take PrEP. We're offering people the option of taking PrEP. And the reason why is because, again, we know that adherence is crucial for PrEP's efficacy. And if people take low levels of drug and develop HIV, their risk of infection goes up. Of resistant infection goes up. How to offer PrEP in the context of a combination of options at preventing HIV. I think it's important to really discuss risks and benefits of each prevention modality. Specifically talking about how condoms prevent other sexually transmitted infections, but also figuring out in that individual's context, are they able to negotiate condoms? One of the really exciting pieces about PrEP specifically for women is that this is a discrete, individually controlled and private option that people can take in advance. For individuals, and again, women are particularly important in this arena. For people who haven't been able to negotiate how to use condoms and protect themselves against HIV, this is an option that really gives people autonomy. And so on an individual level, it's assessing people's individuals' risks and benefits. It's assessing their ability to take a pill every day. It's assessing whether they are able to negotiate condoms or not. Importantly, there have been studies that show that we don't think that risk compensation, meaning that people stop using condoms when they start using PrEP, is really what's happening. Just the opposite. PrEP is actually being used by people who weren't using condoms before. It's not that PrEP makes them start using condoms, but at least we're offering a prevention method to people who are incredibly high risk of infection.
Thank you, Dominika. And with that, I think we will wrap up the webinar. Thank you to all of our presenters who did a fantastic job of not only summarizing the guidelines and giving a detailed explanation of what the guidelines say, but also presenting the nuances of implementation in regards to adapting it to local context, taking into account the health system functioning and structure, as well as various service delivery modalities. So thank you to Dr. Meg Doherty, Dr. Shafika Saji, Dr. Martina Penazzato of WHO, to Dr. Eleanor Namasoke Mugongo of the MOH of Uganda, as well as to Dr. Dominica Seidman of the University of California of San Francisco for preparing these wonderful presentations and giving us an in-depth look at the WHO's early release guidelines on when to start ART and PrEP. So any last words from WHO or any of our presenters?
Thank you very much, Jessica, for really supporting and putting together this webinar, and for giving WHO the opportunity to disseminate this important part of our guidelines, and looking forward to have other opportunities to share the rest of the guidelines, which we are still completing right now, and that will be ready by the end of the year.
Great, thank you. Any other last comments from our presenters?
Thank you very much for giving us the opportunity to share our experience in Uganda.
Thank you for being here with us. Okay, and thank you to our audience for staying with us. We know we went a little bit over, but hopefully the information in the presentations will be very useful as you consider implementing and adopting the guidelines. Thank you again, and hopefully we will see you on our next IATT webinar. Thank you so much.